You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 6, 2022. This week, some comments on HRS, conduction system pacing, atrial fibrillation in the emergency department, a possible new treatment for vasovagal syncope, and women in electrophysiology. A few general comments on the in-person HRS meeting in San Francisco last weekend. EP is a small enough subspecialty that you get to know people over the years, and it felt so good to see old friends and colleagues in real life. There were conversations and handshakes and lots of hugs. And this included a fair number of international friends, and this was really nice. On a personal note, I was happy about my talks that I gave. I debated Vivek Reddy on left atrial appendage occlusion, and the show of hands at the end of the debate revealed the usual. I lost. But the debate was held in the biggest room of the Congress, and it was incredibly well attended, which means that many people got to see my slides, which show the data. And it's the data on percutaneous left atrial appendage occlusion that tells the story on why this procedure is a bad idea. My second debate was lower key, and I took the antagonist position that AF ablation should be first-line therapy in athletes with AFib. My argument here was not that AFib ablation should not be used in athletes, but that we should try other things first, like risk factor modification, simply waiting, detraining, and then ablate AF if it persists. And I have personal experience here, and is that I had AFib during a run-up to a national championship in bike racing, and the Voltaire approach, the waiting approach, worked. My AFib slowly dissipated, and I avoided having any thermal energy in my left atrium. I gave a brief critical appraisal of the East AFnet trial, which was early rhythm control versus standard of care, and proposed what future trials should look like. This was a really good session, and one thing it made me think about is that I'm not sure that we can actually design a study in atrial fib strategies per se. And the problem with AFib is that it's such a diverse condition, right? You have young people who are affected in much different ways than, say, an elderly person with heart failure with preserved ejection fraction and other comorbidities. My final talk was on social media, specifically how to handle disagreement or being wrong on social media. While I believe in the power of social media, I have too slowly learned some basic lessons. Number one, never argue on Twitter. Number two, to persuade, use long-form formats like podcasts or blogs. And three, if you are employed and want to stay employed, avoid politicized issues such as COVID, period. Okay, some studies from HRS. First thing to say is that there were no groundbreaking Cabana-like papers. Nothing got in New England or JAMA, but there was important news, some of it very exciting. Now, first is conduction system pacing. For my entire career, pacing has been like the offensive line of EP. It's necessary, but it gets little attention. Catheter ablation has been like the quarterback and running back and receivers. Ablation basically hogs all the attention. But at this year's HRS, pacing made its comeback into the limelight with the rise of conduction system pacing. 3 late-breaking trials addressed the role of placing a lead in the rapidly conduction His-Purkinje system or specialized conduction system. As many of you know, I've been an early adopter of His bundle pacing, but now the field has moved on to left bundle pacing. Left bundle branch pacing is easier to do, and it produces far better pacing and sensing thresholds, like better R waves and lower pacing thresholds. The pacing lead, captures the left bundle on the left side of the septum, or at least it excites the left bundle early. And when you do that, you get synchronous LV and RV contraction, and you produce these beautifully gorgeous paced QRS complexes with a little bit of right bundle branch block. But until HRS, we really had little data. I have a column coming on this topic soon, and I'll only hit the highlights today. The first of the 3 trials was the LBBAP Resync randomized controlled trial, and it compared the efficacy of left bundle branch pacing to conventional biventricular pacing in 40 patients with heart failure who were eligible for CRT, cardiac resynchronization therapy. The primary endpoint was echocardiographic. It was the change in left ventricular ejection fraction from baseline to 6 months follow-up. And both pacing techniques, left bundle branch pacing and BIV pacing, improved the EF from baseline. But the between-group difference in the ejection fraction was greater in the left bundle branch pacing arm than the biventricular arm by a statistically significant 5%. The secondary endpoints, such as reduction in left ventricular end systolic volume, NT-proBNP, QRS duration, all favored left bundle branch pacing over BIV pacing. There was a second late breaker. This was from the Geisinger group, led by Pugel, Vijay Arman. This was simultaneously published in the Heart Rhythm Journal. This was a non-randomized observational study comparing patients eligible for cardiac resynchronization therapy treated at 2 health systems. One group of doctors favored doing conduction system pacing. Another group of doctors favored traditional biventricular pacing, and this set up a 2-armed, non-randomized comparison. And conduction system pacing was accomplished in this study by either left bundle pacing in 2/3 or His bundle pacing in 1/3. The primary endpoints was death or first hospitalization for heart failure, and it was better in the conduction system pacing arm, and it was statistically significant. Importantly, QRS duration and EF also improved from baseline in both groups. The third study was left bundle branch area pacing as a bailout for failed CRT. It was also from the Geisinger group, and it was an international multi-center study, and it assessed the feasibility of using left bundle pacing as a bailout when standard biventricular pacing did not work, usually because of inadequate coronary sinus anatomy, but sometimes also because of CRT non-response. This series is about 200 patients who had failed CRT and underwent attempted left bundle branch pacing. The bailout was successful in 90%, and the primary endpoint was defined as an increase in EF over 5%. And about 2/3 of patients had an improvement of EF above 5%, and nearly 1/3 had a super response. And similar to previous studies, left bundle branch pacing resulted in shorter QRS duration and improved echocardiographic parameters. So my comments on these 3 studies. Look, I know these are small RCTs and non-randomized comparisons, and it's not what we're used to in big drug or device trials, but this is a start. And so my take-home is that taken together, we learned that left bundle branch pacing appears to increase the EF similar to CRT. It can be used as a bailout when CS leads fail. And this gives me the sense that when RV pacing is expected, left bundle branch pacing is likely to prevent pacing-induced cardiomyopathy, which is a real problem. I am not yet persuaded on a clinical outcome study. The Geisinger study was non-randomized, and because it's non-randomized, you simply cannot infer that left bundle branch pacing caused the better outcomes, because there are likely other reasons, what we call confounders, that led to the left bundle branch group having better outcomes. But these preliminary data also give me confidence that we're on the right track, and that there is surely enough equipoise to compare this technique to biventricular pacing. And if we compare it, I think non-inferiority is a fair way to study it, because left bundle branch pacing is less invasive and less costly. And this, if I have a pacemaker, I want a left bundle branch lead. Okay, next topic is the emergency department triage of AFib. A study from a prominent group of doctors addressed the issue of triaging patients who come to the emergency department because of atrial fib. And this is a hugely important topic, because oodles and oodles and oodles of patients with AFib meet the healthcare system first time in the emergency department. And some of these patients get great care and some get bad care. Okay, so one way to triage patients with AFib is to send them to general medicine or general cardiology, but this Kansas City-led group had another idea. They said, let's give the emergency department clinicians a hotline to an EP doctor. And I mean hotline. The ED docs in this study simply faxed the referral to the EP clinic, and then the clinic was basically asked to get the patients in relatively quickly, and they did. The control group of this study received standard care by the emergency department clinicians with no concerted effort to consult EP. This was a retrospective observational study without randomization. Now, the presenters told us that the primary endpoint was time to definitive therapy. Now, right off the bat, I hope the modifier definitive awoke you. I'll come back to that in a discussion. They had secondary endpoints, and these included MACE, major adverse cardiac outcomes, and bleeding outcomes, as well as clinic visits and cardioversions. The study had about 200 patients in each group. Now, there were many differences in baseline characteristics, as you would expect in a non-randomized comparison. And of course, everything favored the EP consult group. Time to EP evaluation, 1 versus 128 days. Time to ablation, 52 versus 188 days. Time to antiarrhythmic drugs, 3 versus 25 days. And time to oral anticoagulation, 2 versus only 17 days. Length of stay also better in the EP group. The secondary endpoints, number of hospitalizations and cardiovascular-related ED visits, were lower in the EP consult arm. But actually, the number of clinic visits were not different. The authors were very clear in listing the limitations of the study and concluded that the study provides evidence that having an organized pathway for AFib patients can lead to improved outcome times for AFib ablation, drugs, anticoagulation, and length of stay. And the lead author of the paper said this in a news report: the findings suggest a single intervention of appropriate EP consultation that is directed from the emergency room would lead to better outcomes, in part by, quote, mitigating the inherent hurdles in navigating patients through a very complex healthcare system. Okay, my comments. First, let me say that I think early involvement of EP in patients with AFib will lead to benefits. It's literally what we do. We believe in what we do. But this study does not come close to showing that our care leads to better outcomes or less cost. All it shows is that a group of non-randomized AFib patients who have a hotline to specialists get more therapy and get it faster. And even if this study was randomized and had balanced arms, which it wasn't, all this early intervention is just a surrogate. It may or may not be a good thing. For instance, for the most important AFib treatment, stroke prevention, oral anticoagulation, the difference in initiation in the two arms was less than 3 weeks. That is hardly clinically relevant. It's not clinically relevant. What's more, everything about this study is set up to be positive. If you give a busy emergency department clinician a hotline to a consult, they'll be happy to rapidly refer these patients on. And secondly, EP docs are financially and intellectually motivated to intervene, so it's zero surprise that patients get earlier ablation and more antiarrhythmic drugs. And as the authors note, there was more paroxysmal AFib in the active arm and more persistent AFib in the control arm, so it's obviously more likely that paroxysmal patients get more antiarrhythmic drugs and ablation. Another problem. I went to the clinicaltrials.gov website, and I would encourage you always to do that when you're evaluating studies. This is a place where scientists are supposed to describe their experiments before the experiment. Now, here it says that there are 3 primary endpoints in this study, not just one as presented in the late breaker. Their first primary endpoint on clinicaltrials.gov was cumulative resource utilization in dollars. The second, time to definitive therapy, but antiarrhythmic drugs and ablation. And 3, the number of hospital and clinic visits. Well, on the first primary endpoint, they presented no data. On the second primary endpoint, there were just antiarrhythmic drugs and ablation, but in the presentation, they included drugs, ablation, and oral anticoagulation. And on a third primary endpoint, which they called a secondary endpoint in the presentation, this was not statistically significantly different. All I will say about these change in endpoints is that it is concerning, especially for a late-breaking clinical trial at a major medical meeting. And look, I feel bad being so critical of the study because doing studies is hard, I recognize that. But if you want to be able to make any conclusions about a therapy pathway, You have to either randomize the patients or do a cluster randomized trial where you randomize the emergency departments and then measure outcomes, not how much therapy someone gets. To make any positive conclusions from this data, I would characterize as hype or extravagant promotion. And indeed, such conclusions give fodders to the George Bernard Shaw type cynics of medicine. Okay, next topic, cardioneural ablation. Now, my friends, this could be a huge thing. We have all seen patients with severe bradycardia from excess vagal tone. The most worrisome and difficult patients are those with terrible vasovagal syncope who can have pauses of many seconds, 10 seconds, 20 seconds, and then have sudden syncope with injury. And when this happens to older patients, a pacemaker can help. Not cure, because remember, the vagal surge in vasovagal syncope involves both severe bradycardia and severe hypotension, and a pacemaker only takes care of the bradycardia. But I ask you, what happens when such profound bradycardia and vasovagal syncope happens in a 20 or 30-year-old? You don't want to put pacers in young people. Well, a few motivated champions have begun to study the use of ablation, yes, ablation, in the areas of the autonomic inputs of the heart, the ganglionic plexi. These are located close to the areas we ablate during AFib, near the pulmonary veins, for instance, but also near the SVC aortic junction in the right atrium. Right now, there's no billing code for cardioneural ablation. It's only done in a few centers. At HRS, Dr. Rod Tung presented results from a registry of 76 procedures in 13 centers. Again, I said this was early. About 2/3 of the time, cardioneural ablation was done during another procedure, such as AFib ablation. The idea here is to reduce the vagal response, and this can be measured simply by higher heart rates and less heart rate variability. In fact, many patients who have just standard AFib ablation note higher heart rates. During his presentation, Dr. Tung showed examples of heart rate increases and PR shortening during the cardioneural ablation procedure, again, consistent with ablating the vagal response. Here were the main results. At a median follow-up of about 8 months, 82% of the patients were free from syncope after a single procedure, and 5 patients underwent repeat ablation. The median episodes of bradycardia went from 6 to 0. Now, Dr. Tung's next slide and comments clearly listed the huge limitations in this basic case series. This is a case series. There was non-uniform diagnoses, approach to the ablation, and even endpoints. There was no control arm, and of course, no one knows how long vagal denervation will hold for. I mean, if it holds for many years, that's great, but what if it holds for only 6 months to a year? I've not done this procedure yet, but I'm thinking about it. Young patients with profound bradycardia and syncope have very few good options, and if this works and eliminates symptoms without a pacer, it would be a huge advance. But this must be studied in proper form, and that means a sham-controlled randomized trial. That is because almost every therapy that has been proposed and tried for vasovagal syncope has failed to pass muster when it was studied in a proper placebo-controlled trial. And I'm glad to hear that the cardioneural ablation proponents tell me that a sham-controlled trial is in the works. That's great news. This is very, very exciting work, and I appreciate the caution expressed in this presentation. Okay, final topic today is women in electrophysiology. 2 studies presented at HRS reported on extremely low numbers of women and underrepresented minorities who practice EP in the United States. For instance, results showed that on average, only 5% of the 3,500 EP operators are women. And a second study looked at trainees, and it found very low numbers of women and underrepresented minorities who choose to study EP. Okay, my comments. It's strange that we have so few women and underrepresented minorities in EP. I travel in both the cardiology and EP world, and in cardiology, say at the recent ACC meeting, I saw lots of women and underrepresented minorities, especially younger ones. And my group is almost half women. 2 of our 5 interventionalists are women. Another strange thing is that EP would seem well suited for work-life balance. I mean, we work hard and we think hard, but we don't do a lot of emergencies. Rare is the EP STEMI, which is my name for heart block in the emergency department that needs to come up to the lab for a stat pacemaker. And in 25 years, I've only done 3 emergent ablations in the early morning hours for VT Storm. I'd love to see more women and underrepresented minorities do electrophysiology. And for any listeners who are thinking about career choices, you should know that EP is a beautiful field. I cherish it nearly every day on my bike ride to work. We do procedures and we do doctoring. It's the best of both worlds because you use your hands and your noggin. And get this, catheter ablation for AV node reentry, WPW, atrial tach, and some VTs is actually a cure. Tell me how many other fields in cardiology can boast having cures. So come join us in EP. It's a great job and it's filled up with meaning. And so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a little tiny review. These things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.